Good afternoon, everyone. It's my pleasure to introduce Dr. Vignesh Dhananjayan, who's a passionate advocate for trans inclusion in medical spaces. Vignesh is a peer educator and provides support to people living with HIV, transgender individuals, sex workers, people seeking HIV testing, prevention services like PrEP and PEP, through organizations like Safe Zindagi, YRG Care Hospital, Sahodaran, and Sati in and around Chennai and Perambalur. Through this, they continue to improve access to HIV services and queer affirmative care for the communities. Vignesh is currently studying in Dhanalakshmi Srinivasan Medical College and Hospital and identifies as a trans non binary person. They have contributed significantly to influence policy making and reframing medical curriculum by being a panelist and consultant on several platforms. Vignesh was a panelist in the national level policy making event organized by the Ministry of Health and Family Welfare, NACO, UNDP, and USAID, which created an action plan on the theme LGBTQI plus health in December 2021. Vignesh also represented the inputs of transgender and non-binary medical students at the national level Transcare MedEd conference in 2022 to frame medical curriculum that is trans affirmative, which was later suggested to the National Medical Council. As a medical student, Vignesh was selected as a Transcare Queer Ambassador for their college under the project by Sangat, University of Chicago, Kasturba Medical College, and spearheaded the Diversity and Inclusion Club at the college. Their research includes understanding PrEP accessibility among transgender and MSM community. With this inspiring background, I request Vignesh to shed some light on the topic titled The Disproportionate Impact of HIV and Access to Care Among Vulnerable Communities.
Thank you, Dr. Swathi, for the introduction. I would also like to thank CMC for this opportunity to discuss this important topic at this forum. The disproportionate impact of HIV among vulnerable communities. This presentation is not just my perspective as a peer educator for queer individuals accessing HIV care. It also brings in the perspective of Shubhangani Jain from Solidarity Foundation, their research perspective from ground level about how female sex workers and gender and sexual minorities access HIV care, and as a peer educator, my perspective on how queer individuals face hindrances to accessing HIV care, and Dr. Praneeth's perspective on addressing these hindrances in HIV access. As we can see, the prevalence of HIV has been on the decline trend all over India, but still the prevalence of HIV among vulnerable communities like female sex workers and transgender community and MSM has been the same. And one of the most important factor that drives the increased prevalence is stigma and discrimination, as we can see from previous studies. Speaking of stigma, there are a lot of reasons as to why there is an increased prevalence of HIV only among the key populations like female sex workers, TG and MSM communities. And we can see certain factors from here from the previous studies. A lack of economic and social security and job opportunities is an important factor. This holds especially true for transgender communities where the only source of income for them is either through begging or through sex work. And the other is intimate partner violence and family non-acceptance. And another most important factor is an unresponsive healthcare system where they don't understand the needs of a trans person or MSM community and don't give a person-centric care for HIV care for people from these communities, and also lack an understanding about preventative services like PrEP and PEP for the gender and sexual minorities. And there is a lack of power to negotiate condom use with their partners. This holds especially true for trans communities engaging in sex work and female sex workers, and an unsafe work environment and inadequate legal protection for transgender communities and female sex workers. And the most important is the stigma and discrimination relating to one's own identity belonging to a vulnerable community and the work that they engage in, which is sex work. Speaking of stigma, the most important community that faces double marginalization basis on their identity and the work they do is the transgender community. This is a diagram from Dr. Venkatesh Chakrapani's research as to how syndemic factors come into play and which predisposes transgender community to having higher prevalence of HIV. As we can see, being a transgender person itself is a hindrance to accessing HIV care. And there is a HIV-related stigma, which is at the both patient end and also the provider's end. and stigma relating to sex work. And there is another important factor which healthcare workers frequently miss, which is the unmet gender affirmation needs, that is the HIT services taken by a transgender community is not always taken into consideration while providing ERT services to trans community. All these things act in a syndromic manner to um, drive conditions like depression and alcohol use in the vulnerable community like trans community, which subsequently goes on to add health-related outcomes like delayed ART initiation, ART non-adherence, and HIV decay disengagement. So the primary objective of the session will be is to understand what are the hindrances to HIV access among the vulnerable communities like female sex workers, transgender, and MSM community through case scenarios, and to address those using clinical approaches, and to how to address the hindrances that they face. So how far is the current healthcare system and HIV programs meeting the needs of vulnerable groups? We'll be discussing this through case scenarios. So this is the first case study. This is a real life case scenario which I handle as a peer educator. So this was a 27-year-old gay man who comes with an OPD with a history of sexual abuse 2 weeks ago by two men who he met who he met through a dating app. And he was scared of contracting HIV because he did not know the HIV status of his perpetrators, and he was sent for an HIV testing and was eventually found to be positive. What happened to him after post-test and after finding out he was HIV positive is the primary discussion of this case study. The issues faced by patient 1 at this ART center. After the test results that he was found to be HIV positive, he was given a post-test counseling. So there is usually a post-test counseling after the test and before initiation of ART. The ART counselor at the ART center, which is the government counseling center, made sure that my patient will never step into an ART center ever again. What did he do to make the patient do that? A list of things is here. The first is victim blaming and shaming the patient for getting sexually assaulted. Intrusive questions like, why were you dated to begin with? Why did you go meet an unknown man from a dating app? Aren't you a man? Can't you even fight a man when they sexually assault you, were asked. So these kind of questions stems from the HRT counselor's bias of homophobia, one. And second is a patriarchal notion that a man cannot be sexually assaulted. And second is pathologizing sexual orientation and stigmatizing his identity as a reason for him getting HIV and getting sexually assaulted, which also comes to the point of stereotyping that only particular kind of people with sexual orientation, gender identity, tend to have a higher chance of getting HIV, which is not the case though. And on top of all of these, there was an NGO worker at the RT center who, quote and unquote, gave a magical cure for HIV, misled my patient into believing that there is a cure for HIV, which he can, for which he can get medications from a Bangalore private medical center. And it took a lot of effort to convince my patient to not stop ART medications in between after this NGO worker intervened. So this is not an isolated incident. So this is a quote by a Koti person or a transgender person, which is taken from a research by Solidarity Foundation, where they frequently see, especially trans people, as a nuisance at the ART center. They see them as a problem instead of a person seeking solution to a problem. And there, many a times we see trans people sent back without even treatment at the ERT centers, because a lot of things come into play at the ERT center as to if they're getting admitted even as a patient, apart from the ERT center, if they're admitted as a patient, where should we place a trans person? Should we place them in a male ward or a female ward? Do they have bathroom accessibility within the hospitals? All of these comes into play, which again makes a trans person to hesitate to go to hospitals. So the considerations for providers to care for this patient, even before the need to initiate an ART and making the patient adhere to it, the most important thing that will make a patient adhere to ART is an affirming post-test counseling, which a lot of times care providers don't take into consideration. Here in this case, if the post-test counseling was given in an affirming manner, my patient would have not stopped the ART by 1 week, and eventually after 1 week, he had suicidal tendencies, reporting to me as a peer educator that I'm feeling suicidal, I want to discontinue my ART medications, and I don't want to continue taking ART anymore. So again, we had to connect him to a psychologist and psychiatrist, and had to consult him, make him consult them to adhere to the ART medications. And the next is discussing about family and peer support. And the most important part in this is guiding on legal measures and connecting to reliable sources. As we saw, the HIV counselor had a patriarchal mindset that a man cannot be sexually assaulted, which is not the case. So we have to, even though this person is from the sexual minority, and it is not mandatory for a healthcare provider to report this case, it is ethically an obligation for a healthcare provider to encourage the patient to file a complaint, which is under Section 377, which basically deals with filing complaints under sexual assault that is committed anything other than as a peno-vaginal intercourse, anything other than that, acts of which are criminal, which is unconsensual. And in the same place, if it was a transgender person, the ART center has to encourage the patient to file a case under Trans Protection Act and also under Section 377. And another important thing is trans women are considered legally as a women under the law, so it is essential for them to complain under Section 375 as well. And discussing preventative measures and further follow-up is very important. So the takeaway messages: HIV care has to be a multidisciplinary approach, especially when it comes to vulnerable communities, involving a physician, counselor. In this case, we needed a psychiatrist, a psychologist, and above all of it, we need an NGO or community-based organization, workers from CBOs. This is important because HIV has always been a community-led effort. It has not always been about healthcare workers fighting against HIV. It has always been about community coming together and community leading this effort to driving about HIV. And the rampant pathologizing of sexual orientation, gender identities. Apart from this being a professional misconduct, it will also leads to poor mental health, as we see in this case, and non-adherence to ART and falling out of care in the system. This is especially true for non-adherence and falling out of care from system for trans people because they're very migratory. Once when they migrate to one place to another, it is very difficult to track them back and then make them adhere to ART. And another takeaway message is high vigilance in what words we use, especially if they are from the trans community or for a female sex worker. And the takeaway points for a healthcare provider is to make the people understand the importance of U is equal to U, which is basically when you have an undetectable viral load on ART, you cannot transmit it to your partners. This not only encourages them to make follow-up visits to the ART center, but also encourages them to adhere to ART continuously. And the next point is about prophylactic measures like pre-exposure prophylaxis and non-occupational post-exposure prophylaxis, which we'll be dealing in the next case scenario. I would just like to ask a question. How many of you know about pre-exposure and post-exposure prophylaxis? Quite a good number, thank you. So we'll be discussing in the next session, next case study. So the next case study is a 19-year-old transgender person or a Poti person visiting an ART center, telling that their partner coerced them into having an unprotected sex with their partner, which is basically the partner removed the condom without the permission of the transgender person. And the partner, the trans person immediately went to a center in Chennai, which is VHS Hospital and YRG Care, within 24 hours, which was very fortunate. And they wanted to know if they're HIV positive or not, or if there is any implications of having such unprotected sex with their partner. So a swift care was given to this particular patient, and the patient was immediately sent to a primary care physician, and she was given what we describe as non-occupational post-exposure prophylaxis, which is very important when it comes to vulnerable communities, because a lot of times we have had patients, especially from the gay community and the transgender community, having condom breaks and also sexual assaults like the first case, and we refer them to an ART center to get post-exposure prophylaxis, but are refused post-exposure prophylaxis and told to come after 3 months to get tested to see if they turn positive or not, which should not be the ideal case. There are guidelines by NACO and also by CDC recommending non-occupational post-exposure prophylaxis, not just for sexual assault survivors, but also for condom breaks. So this particular case, a trans person was started on tenofovir, lamivudine, and dolutegravir combination, and she was given pre-test counseling. After 28 days of PEP, she was tested. Fortunately, she turned negative. And also subsequently, she was advised to bring her partner for testing. And he was tested, and eventually he was found to be HIV positive. So prophylactic measures to prevent HIV was given to the transgender person. And for the person who turned HIV positive, the partner, the importance of adherence to ART, U is equal to U was given. Counseling was given. So further consideration, and takeaways. I know it's not a mistake. 2 considerations, because you have to twice consider this messages from this slide especially. So first, you have to appreciate a transgender person coming within the stipulated time asking for care, because she has made the right decision. And even more important is a healthcare provider giving timely intervention to this person. And the need to provide pre-exposure prophylaxis in a timely and non-judgmental manner. There is a misconception that pre-exposure prophylaxis cannot be started for a trans person if they are on hormone replacement therapy. this is not the case. So you can start pre-exposure prophylaxis or ART drugs or even post-exposure prophylaxis regardless of their HRT status. And there is only one anti-androgen drug, which is a little bit of contraindication for these drugs, which is spironolactone, which we can even still monitor. With good monitoring, we can still use both HRT and ART. And since this case is primarily dealing with a couple who are in a serodiscordant relationship, basically a transgender person who's HIV negative and another their partner who's HIV positive. And there is also this stereotype that serodiscordant relationships should only be encouraged between a man and a woman. And serodiscordant relationships don't exist in a gay couple or a trans cis couple, which is not the reality. As peer educators, we see a lot of serodiscordant relations between gay men and also among trans and cis couples. So we have to educate them, both of them, around the concept of consent and safety, because one of them is on ART and still HIV positive. And the next important point for consideration is the need to understand this person is not on any other drugs like HRT. The only contraindication for, or you have to take a step back and monitor the HRT and ART interaction is only when the person is on anti-androgen drugs like spironolactone. Other than that, if they're taking any other hormonal tablets like estrogen, it is not a contraindication for any ART medication or PrEP or PEP. So there is a need for comprehensive care where we integrate hormone replacement therapy and antiretroviral therapy. And there is a need for follow-up for adherence and further preventive strategies. And again, I'm stressing on U is equal to U, the need to make the patient understand how undetectable viral loads is very essential for their survival on ART drugs. So next is case 3. So this is a 36-year-old female sex worker from Bangalore. She had a vaginal discharge for 2 weeks and she had a wound around her vaginal area. And she was doing sex work for a living. She was on ART medications and she has been taking it for 5 years. But she did not disclose any of this information that she is a sex worker or she is on ART medications to the healthcare provider. She just mentioned her chief complaints as vaginal discharge. Later, she was examined and she was found to have vaginal candidiasis. And she was found to have higher blood sugar levels and she was hypertensive as well. So the issues in this particular patient is the fear of being outed as a sex worker and facing discrimination by the provider. Healthcare workers comes with an unconscious bias that once they're a sex worker, their identity is known to all, which is not the case. So a lot of female sex workers have families where they do not disclose their identities to their families. So it is essential that you don't make a stereotype or an assumption that sex workers' identity can be compromised at any level during the care. And the next is the inability to share details of being HIV positive and on being ART medications as a sex worker. This comes primarily because of the HIV stigma the sex workers themselves have. And this also is a disadvantage of the healthcare provider because this puts the healthcare provider on a blind end. As so they don't know what drug-to-drug interactions could happen between the ART drugs and the NCD drugs this women would be taking. And at the ART center, the provider seldom gives time to listen to their issues. Here, there is a fragmented nature of HIV care. As to once a person is revealing their HIV status, the ART center people only concentrates on HIV and forgets the NCD. And at the NCD centers, they only concentrate on NCD and they forget that they have HIV. So there is a need for comprehensive healthcare and holistic approach to conditions like this. And for a discussion on sexual health and related sex work and preventive strategies, it is unfortunate that we don't have such spaces within the ART centers to discuss about sexual and reproductive health care of a sex worker, not just a cisgender woman, but also trans people. And again, this is not an isolated incident. Again, this is a quote from one of the researchers by Solidarity Foundation, where a sex worker from Telangana was refused healthcare primarily for the reason that she was a sex worker. And a lot of people had to come together to fight against the discrimination against sex workers at that particular hospital. So the takeaway for this particular case is that there is a need for comprehensive and integrated care. In this particular case, integrating NCD as well as ART care for this person. And breaking the invisibility where the patient hides that they are a sex worker or that they are on ART drugs. This is only possible when you give an affirming space for the person to reveal their identity and you're empathetic towards them. And to discuss sexual health about their sexual health in a non-judgmental manner and reassuring privacy, as they already said, privacy and confidentiality is the only way to win a vulnerable person's trust and a need to reflect on our unconscious biases. So how to strengthen HIV care among this vulnerable community? So we have two ways in which we can do that. steps at a provider level and to address systemic issues. For steps at the provider level, it is essential for us to have a multidisciplinary approach and a team approach for this. And the need for strong counseling services, especially in an affirming manner, affirming their gender identity, affirming their identity as a sex worker or as a gay man. And the need for a comprehensive and person-centered approach in HIV care, and not a paternalistic approach as to this is good for you and this is what you have to take. And respecting their identities and creating non-discriminatory and safe spaces. And also breaking multiple forms of invisibility. Again, this is only possible when you give an affirming space for them to reveal their own identities. That comes with empathetic communication. And being up to date with recent preventative and treatment strategies like post-exposure prophylaxis and pre-exposure prophylaxis. This is especially true for pre-exposure prophylaxis because a lot of times when we refer people from MSM or transgender community to healthcare providers at random to get on-demand pre-exposure prophylaxis, doctors make comments like, in my 10 years of service, I have not prescribed PrEP for anyone. And you're coming for on-demand PrEP. Why should I even prescribe it to you? This is despite 2021 guidelines released by NACO, giving a technical guidelines to prescribe PrEP for healthcare, PrEP for vulnerable communities. So there is an inherent need for us to reflect on our practices and biases and update ourselves based on the recent guidelines. And advocating for patients' rights. And at the systemic level, there is a need for integrating HIV care with primary health, not just primary health, but also holistic approach of including HRT with ART for trans people. And moving beyond clinics, there is an essential need for community engagement. HIV has always been, historically been a community-led effort, right from fighting for finding a solution for HIV from the 1980s. It has been a community-led effort. So it is essential for us to have community leaders at ART centers to refer patients to, and listen to people's realities and problems, and coordinating HIV services. Especially this holds true because a lot of times when the victim is when a sexual assault survivor is from the vulnerable community, like a trans community or MSM community, they are not considered as victims. They're not considered as victims of sexual assault, primarily from the stigma that a sex worker cannot be sexually assaulted, or a person who is trans and engaging in sex work cannot be sexually assaulted. These biases should be broken down. And there is a need for integrating gender and sexuality and transgender health needs into the medical curriculum. So the questions to the providers to reflect, to change their practices: do I behave differently when a transgender person comes to my clinic? If yes, what are the differences that I feel about that person? And why do you feel different when a trans person comes to your clinic? And you have to understand as these differences has any impact on the client's interest or healthcare. And also the important question is, do you make assumptions about a person's gender identity based on their appearances? A lot of time, feminine gay men could be mistaken for being a trans person, and you would treat them like a trans person, which is not the case. So you have to ask them, do I have any inherent bias? Am I assuming a person's gender identity based on their appearances and clothing? And other questions like, do I refuse to consult a patient because they are having HIV, or because of the gender identity or the sex work that they do? What are my feelings about it? And is there a contraindication about this? Is it contradicting my duty of care to these patients? And the other question is, final important question is, can I call myself as an ally to gender and sexual minorities? If yes, why? If no, why not? So I leave the audience to these questions and ponder upon these. And thank you for the wonderful opportunity.
Thank you, Vignesh, for bringing up such an important presentation in a very sensitive and also comprehensive manner. I would like to open up for questions and then maybe share. Okay, the question is, other than for assessing risk levels, is there a reason for clinicians to know a patient's sexual orientation at all?
I feel yes, because a lot of times patients have a stigma about their own sexual orientation, that they will hide that they're having particular sexual orientation. And most of the times they also tend to hide their sexual history along with their sexual orientation. So it is essential for us to know their sexual orientation, and it is only possible that when they create an affirming space, they'll know that what is their sexual orientation. Also, there are people who do not accept their sexual orientation, but tell, I am not a gay man, but they will still be engaging in sex with other men. which is exactly why we frame the term MSM, men who have sex with men. They don't necessarily, men who have sex with men, necessarily don't identify as gay or bisexual. They could just say, it is, I don't consider it as sex. A lot of gay men who have sex with men don't consider their sex with other men as sex at all, because it is not for procreation purposes. So in an affirming manner, based on patient to patient basis, it is essential you ask the right questions to the person to know their orientation and sexual history. So yes, it is essential for us to know their orientation.
So you're basically saying that the definition of what people think as sex actually changes from person to person, which is actually a really interesting
yes.
observation.
Also, not the people's perception. The perception of a person who is themselves
Correct.
Also differs.
Right.
They don't necessarily identify as gay because they have sex with men. A lot of it is because of internalized homophobia that they have.
Okay.
Any other questions? Okay, there is a question online. What are the common medical care needs for them?
Them in the sense we have three categories. So
maybe you can touch upon each of the categories.
I think I'll start with the trans community. A lot of times we only focus trans community in terms of ARTs alone, as in HIV alone. We often tend to forget that they're also on parallel HRT, hormone replacement therapy. A lot of times we miss the drug interactions between HRT and ART drugs. Now that the most famous infamous anti-androgen drug that trans people are taking is spironolactone, which is known to have a potassium sparing effect. And we also have deaths related to cardiac events because of the drug interaction between ART drugs, and nephrotoxic effects on kidney because of using spironolactone and with ART drugs. So it is essential to understand the comprehensive care as to how to monitor a patient who's on HRT and as well as ART. This holds true for trans people. And also being on hormones also increases a lot of other potential effects, including a lot of trans people are more prone to have substance abuse, which also leads to a lot of other NCDs like diabetes and hypertension. And so hence comes a need for integrating other sexual health needs as well as the NCD diseases that trans people are more prone for. When it comes to MSM community, I don't think, except for sexual and reproductive healthcare, they necessarily face other discrimination in terms of their gender. Since it is only the only discrimination that they face is based on their sexual orientation. That is the part we should address as to the takeaway messages as to affirming manner, not pathologizing their sexual orientation. That part. Regarding the gender part, they get other services as to NCDs and other common healthcare services that they need. MSM people usually get it without any hindrances.
So this is something that there was a talk yesterday about maternity, abuse and disrespect in maternity settings. And one of the comments that was made at that time was a lot of the abuse stems from a disrespect towards a woman being sexually active. And the conversation yesterday went off into conversations about how do you actually sensitize doctors to normalizing sex itself. And it does seem to me that you are also bringing up some of those same kind of themes of just the fact that somebody is sexually active makes them at a higher risk for abuse or bias. You are a medical student yourself. In your opinion, how do you think medical students should be taught or sensitized to normalization of sex?
I think first we should begin with the fact that we should not consider sex as the only means for procreation. And it stems from the fact being sexually active is wrong. Also, partly the reason why they consider it wrong is because it is only meant for procreation is their primary thinking, which should be broken. And also, you cannot, not everyone who has sex does that because they want to procreate. That idea must be instilled into the curriculum. And also, just because someone, and especially I want to bring this up at this conference because it is essential. A lot of people, like straight people, like as in a man and a woman, when they have sexual problems, they go to a doctor, someone, a sexologist, an andrologist, or a gynecologist for the sexual healthcare needs, like be it vaginismus and all of that. But Have you ever seen a trans person coming to you with problems like, I'm not able to have proper sex with my partner? I have issues in having sex with my partner. Why is it stigmatized that a trans person having sex with a partner is such a taboo topic? Pleasure of sex is not just meant for people, man and a woman. It is, it is a universal concept, pleasure from sex. And even that is unequitable for a lot of trans and queer people. So it is essential for us to understand that sex is not just meant for procreation, and it is a right for us. Thank you, Susan. And for us to understand that it is not just for means of procreation, it is also a right to have pleasure with our partners, also a right, which is, I think, also recognized by WHO. Right to pleasure is a right.
There are two more questions, one online and one here. What are your suggestions for medical education?
I think recently we have changes in the medical curriculum of making it queer and trans affirmative based on Sushma versus Assistant Commissioner of Police, the judgment given by Justice Anand Venkatesh. But the only change that we got was in psychiatry and forensic medicine. Incidentally, I was also a part of the consultation by Dr. Balachandra from Psychiatry NIMHANS when they were making suggestions. I also had to bring up a point about how conversion therapy in all its form have to be removed, including when voluntarily they come for conversion therapy. There was a section called ego-dystonic homosexuality, where if the patient comes for converting the sexual orientation, the doctor can take steps to change it. So I brought this up there, how ICD-11 is removed it, and all of that. But it is only limited to 2 subjects. I guess it has to be implemented across all subjects, including obstetrics and gynecological care for trans men. We are often ignoring gynecological care for trans mask people. They also have the same problems of any other cisgender women. And it is essential for us to screen them for cancer. It is essential for them to have hysterectomy, which often they will go to an obstetrician and gynecologist. So there is a need for including trans mass health issues into OB-GYN, and also HRT related issues into internal medicine. And of course, forensic medicine has changed now, and other subjects as well. Regarding, we learn about a lot of things in anatomy. We don't learn about the anatomy of an intersex person necessarily. We don't learn about the anatomy of a post-op trans woman necessarily. So across spectrum, across all subjects, there has to be a reflection of gender and sexual minorities being represented and the healthcare needs represented in the medical curriculum.
So the question online is about hormone replacement therapy. Women had questioned the need for hormone replacement therapy because of the huge side effects. So in that context, why do transgendered individuals still use it or would continue to use it?
I think they should have a primary understanding about the person with gender dysphoria would need anyway the HRT medication. The only thing that a healthcare provider must make them understand is to what side effects they might possibly have and what can they as a healthcare provider do to prevent those. Some HRT drugs won't work perfectly for others, and some like anti-androgen like spironolactone works for best for some trans women, and hormonal patches works best for some trans women. So in spite of the side effects, the benefits outweigh the risk for a lot of trans women when it comes to HRT, and that is exactly why it is still practice. If there was an alternative solution to change someone's appearance to the opposite gender, they would have adopted it. But the only option now that we have is HRT tablets. It is estrogen tablets. Now it is, I think, it's safer. We have injectable estrogens, and we have even more safer HRT drugs now.
Okay. Thank you so much,
Thank you.
Dr. Vignesh.
Thank you, Swathi. Thank you for the moderation.
Thank you, Dr. Vignesh. I request Dr. Swathi to present to Dr. Vignesh the memento.